Yeah, good evening, gentlemen, ladies and gentlemen. After that talk on twilight trial, let us turn and take a look at lipid lowering in atherosclerotic peripheral artery disease. Now, when we say peripheral artery disease, it encompasses the lower limb, upper limb, mesenteric, renal, and cerebrovascular territory. Now, when you see patient with lower extremity arterial disease, please remember some of them may be harboring coronary artery disease, and few of them harboring carotid stenosis or renal artery stenosis. Now let us look at the benefits of lipid lowering in peripheral artery disease. Now this is the heart protection study where there were 6,700 patients with peripheral artery disease and 13,000 patients without diagnosis of PAD. Now 40 milligram of simvastatin daily reduced the rate of first major vascular events by about 1/4, and that of peripheral vascular events by 1/6, and at a large absolute benefit because of the high vascular risk. So statin therapy should be considered routinely for all patients with peripheral artery disease because that have the strongest evidence base for ASCVD risk reduction. For those not achieving LDL goal on statin monotherapy, ezetimibe is considered the first add-on therapy. If they don't meet the goal even then, one should add PCSK9 inhibitor, that is evolocumab, which is available with us now, because this will produce marked additional LDL cholesterol lowering. And apart from that, it has got anti-thrombotic effects, giving us additional ASCVD risk reduction benefit. Looking at the Fourier trial, which had 27,000 patients of atherosclerosis, 3,000 of them had symptomatic lower extremity peripheral artery disease. And out of these 3,600, 2,000 patients had concomitant prior MI or prior stroke, whereas 1,500 of them had no prior MI or stroke. So when you look at the primary endpoint of death, MI, stroke, unstable angina, and coronary revascularization, patients with PAD had definitely higher risks, but they also derived greater benefit as compared to the patients who had no peripheral artery disease. Number needed to treat here being 29, and here it is 63. When you looked at the major adverse limb events, patients with PAD again had significant benefit, risk reduction by nearly 37%. But interestingly, even those patients without non-PAD had major adverse limb events, and they also showed benefit with use of lipid-lowering therapy. Now, this benefit in patients without non-PAD reflects two things. One is the heightened risk of peripheral artery disease in patients with coronary or cerebrovascular disease. And the second one is the underdiagnosis in populations where systematic screening is not conducted. Now, this is the relation between LDL cholesterol achieved at 1 month with the adverse limb events. Now, lower the LDL cholesterol and lower the risk of adverse limb events. This goes down up to the 10 milligram of LDL cholesterol per deciliter. So lowering LDL cholesterol to very low levels, that was median was 30 milligram in the Fourier study, with evolocumab in patients with symptomatic lower extremity artery disease significantly reduces MACE as well as major adverse limb events. These benefits come with no offsetting side effects. When looking at the composite of MACE and major adverse limb events in patients with symptomatic lower extremity artery disease and no prior MI stroke, evolocumab resulted in an absolute risk reduction of 6.3% at 2.5 years, yielding a number needed to treat of 16. So the clinical implication is that reducing LDL cholesterol levels to a very low target should be a core focus of preventive therapy in patients with symptomatic lower extremity peripheral artery disease, including those patients who have no concomitant coronary or cerebrovascular disease. Now, what's happening in reality out in the field there? There is a therapeutic gap in patients with ACS versus stroke versus critical limb ischemia. In these 10,000 patients from Hong Kong study, 2.5% of them had critical limb ischemia. Now, only 29% of critical limb ischemia patients achieved the target LDL cholesterol less than 70 milligram per deciliter at month 12, significantly less than stroke patients and ACS patients. And use of statin therapy also was lowest in critical limb ischemia patients, 52.6% versus 88.4% in acute conditional patients. When it comes to use of high potency statin, again, only 2% of critical limb ischemia received high statin therapy as compared to 21% in acute conditional patients. Topping over that, at 12 months, 51% of critical limb ischemia patients were not on lipid-lowering therapy, as compared to only 28% of ACS patients. What this demonstrated is that there is significant therapeutic gaps in lipid-lowering management in high-risk patients. Critical limb ischemia patients in particular were less aggressively treated with lipid-lowering therapy. This is coming to a study in US where they looked at 125,000 patients. Though the statin prescription rate improved from 75% in 2014 to 87% in 2019, only 30% of patients not on statin at the time of intervention were discharged with statin. New statin prescriptions rates were lower in women, showing the gender bias. Statin use was lower after endovascular intervention, only 26% receiving statin, compared to the surgical patients who received 41% of receiving statins. So in this cross-sectional study, although statin use was associated with substantial improvement of lower extremity revascularization, more than 2/3 of patients not already taking a statin pre-procedure remained not taking a statin at discharge. It's very disheartening. Now, what is the way to go to reduce this gap? Once you see a patient of peripheral artery disease, you must assess his atherosclerotic cardiovascular disease risk. The intensity of lipid lowering should match the risk. Now, put the patient into one of these risk categories based on the major risk factors, non-conventional risk factors, into either low risk, moderate risk, high risk, or very high risk. Now, all peripheral artery disease patients, since they have atherosclerotic cardiovascular, they come into high risk. Now, if this patient has one of these high-risk features, he goes into extreme risk category BA. And if he has one of these additional very high-risk features, he goes into extreme category B. Then you have the LDL cholesterol goals laid down for these risk categories. If he belongs to extreme risk category B, his LDL cholesterol should be 30 milligram per deciliter or less. If it is BA, it should be 50 milligram per deciliter or less. The core primary target is non-agitated cholesterol, so that it takes care of triglycerides. Now, how do we achieve these goals? We must reinforce the lifestyle interventions, take optimal control of diabetes and hypertension, use high-intensity statin. If not at goal, use ezetimibe. If not at goal, use PCSK9 inhibitor. Hyperglycemia is another risk factor for atherosclerotic cardiovascular disease. And as shown in the REDUCE trial, compared with placebo, icosapent at 4 grams per day significantly reduced total cardiovascular events by 30% in those patients who were on maximally tolerated statin therapy and had achieved an LDL goal of less than 70 milligrams per deciliter. Now, analysis of first, recurrent, and total events demonstrates the large burden of ischemic events in statin-treated patients with baseline triglyceride more than 100 milligrams per deciliter, and the potential role and benefit of use of icosapent in this particular group. Lipoprotein(a) is another frontier to take care of because analysis in 3 independent population studies and the genetic study has shown a causal relationship between LPA and peripheral artery disease. And elevated LPA also has shown a heightened risk of ischemic stroke in this study of nearly 50,000 individuals from Copenhagen General Population Study. So lipid association recommends that one should estimate LPA in all at least once in their lifetime, and definitely in patients with premature atherosclerotic cardiovascular disease, FH, family history of premature coronary disease, poor response to maximal lipid loading therapy, ischemic stroke of uncertain etiology, and calcific aortic valve stenosis. So in conclusion, Chairman, ladies and gentlemen, atherosclerosis is a systemic disease affecting multiple vascular beds, and peripheral artery disease is an indicator of an advanced atherosclerotic process and is frequently associated with preclinical or clinical atherosclerosis in other territories, which imparts very high negative prognosis. All too often, patients with peripheral artery disease and polyvascular disease receive less aggressive secondary prevention therapy and risk factor modification than patients with coronary artery disease alone, although the benefits of guideline-based treatment have been proved. Thank you for your time.
Thank you, Dr. Iyengar. That was indeed wonderful. And I must say the Lipid Association of India has actually come out with very, very provocative and very required and necessary and apt guidelines. And the good thing is that these things are being acknowledged all over the world. People are accepting lower the better. And there is a lot of data now which proves that lower the LDL, the better you are, and what is the advantage of aggressive lipid lowering. And you have been pioneering this work, and this, it's like a crusade for you. And Dr. Puri at our place, and we can see it happening and revolutionizing the care, the adherence to lipid lowering agents, the knowledge of hyperlipidemia, the potential benefits of lowering it to a particular level. And that has really changed the way physicians now are thinking and practicing medicine and cardiology and diabetology. And I must salute your effort and the efforts of Lipid Association of India and Dr. Puri's work that you have gone. The amount of work, I know that how much of effort and work you have done, and actually gone from places to educate the physicians, to educate the clinicians about this, the epidemic of coronary artery disease and peripheral arterial disease, and how lipids are important and what is the rationale of lowering it to that level, and making them accept this fact that lower the better. Otherwise, as you said, very, very poor percentage of patients, very low percentage of patients actually were on optimal level of drugs and actually were achieving the target levels. So with this, I will, ask you to, being a panelist and the chairperson, to conduct the discussion. We just have 5 minutes for the discussion because we are a little late, and we have another 2 talks coming from United States on vascular robotics.
Thank you, Dr. Khanna, for those kind words. I have one question for Dr. Pandey, my good friend. Dr. Pandey, do you have any data on the gender, the women patients within this twilight trial?
No, sir, I don't think there is a women analysis population. In that, there is a difference between males and males and females, and there was no significant difference there. So the females also tended, usually females are considered to have a little higher bleeding risk. So the net clinical benefit in elderly females were higher than elderly males. But overall males and females, I don't have that data, sir.